morning, everyone. Today we are going to discuss arterial thrombosis predictors. Arterial thrombotic disease, including peripheral vascular occlusion, AMI, and cerebrovascular ischemia, arises from arteriosclerotic plaque. Eruption of unstable plaque mediates platelet-driven thrombosis formation. The traditional predictors of arterial thrombosis risk are elevated total cholesterol and low-density lipoprotein cholesterol, or an elevated ratio of total cholesterol to high-density lipoprotein cholesterol. Secondary to HDL-C deficiency. One-third of primary cardiovascular and cerebrovascular events occur in patients whose lipid profiles are normal. However, in half of people with proven lipid risk factors never experience an arterial thrombotic event. So, ATP researchers have been studying factors to predict arterial thrombosis, such as different types of lipoproteins and markers of inflammation. They've also looked into components of the fibrinolytic pathway like PAI1 and TAFI, as well as factors like fibrinogen, factor VIII, and von Willebrand factor, which increases during inflammation, along with activated platelets. Patients with arterial thrombosis are typically treated with statin to lower the cholesterol, anti-inflammatories, and drugs that prevent platelet activation. So next is lipoprotein A. Lipoprotein A is a low-density lipoprotein that may predict arterial thrombosis. The plasma level is measured by EIA, although lipoprotein A concentrations are higher in African American than European Americans. Lipoprotein A may contribute to thrombosis by its antifibrinolytic property. The molecule competes with plasminogen for binding sites on newly formed fibrin polymer, decreasing the plasmin activity available for fat degradation. So lipoprotein, therefore, is a type of LDL cholesterol that can indicate a risk of arterial blood clotting. Its level can be measured through a blood test called EIA. While lipoprotein A levels are generally higher in African Americans compared to European Americans, it's a stronger indicator of blood clotting in Caucasian. Lipoprotein A can promote blood clotting by interfering with the breakdown of clots, and it may also increase overall LDL cholesterol levels. Statin medication can help lower both lipoprotein A and LDL cholesterol levels. So the image here is the molecule of LPA and LDL. So next is CRP, or C-reactive protein. CRP is a calcium-dependent pentameric ligand binding member of the pentataxin family. It is produced in the liver and circulates in plasma at a concentration less than 0.55 mg per liter. First described in 1930, CRP is an acute phase reactant whose plasma concentration rises 1,000-fold 6 to 8 hours after the onset of an inflammatory event, such as infection, trauma, and surgery. Extremely high CRP levels are identified using one of several time-honored manual semi-quantitative laboratory assays performed on a slide or card, all of which employ polyclonal anti-CRP antibodies that coat a suspension of visible latex particles. Laboratory professionals continue to use the simple and inexpensive assay in place of the erythrocyte sedimentation rate test to confirm acute inflammation and monitor the effectiveness of anti-inflammatory therapy. So CRP, as being said, high sensitivity CRP or HSCRP is a test tube to detect small, long-term increases in C-reactive protein levels in the blood. Elevated levels of CRP, specifically at 1.5 mg per liter or higher, suggest the presence of artery clogging, plaque, and ongoing low-grade inflammation, which can increase the risk of heart attacks and strokes. This test is useful because it can predict cardiovascular or cerebrovascular diseases independently of cholesterol levels. Additionally, high sensitivity CRP can help assess the risk of heart attacks when combined with total cholesterol and the ratio of cholesterol to HDL cholesterol. It also used to monitor how well statin medication are reducing inflammation. So next is fibrinogen activity. Laboratory professionals measures fibrinogen using immunoassay, nephelometry, or the closed clot-based method to detect this fibrinogenemia, high fibrinogenemia or afibrinogenemia in chapter 44. The same assay may be used to detect chronic hyperfibrinogemia, which correlates with the relative risk of myocardial infarction in asymptomatic persons or patients with angina pectoris. Relative risk triples from the lowest to highest concentration of fibrinogen, and even chronic high normal levels associate with increased risk. There also exists a correlation between fibrinogen and TC. High fibrinogen concentrates can be used to predict hypercholesterolemia and identify patients who are at high risk for new coronary events. In contrast, low normal fibrinogen levels are associated with low risk of cardiovascular events. Even in people with high TC levels, fibrinogen becomes integrated into atherothrombotic lesions and contributes to their thrombotic patients. So, fibrinogen, the fact that elevated fibrinogen levels can indicate a risk of arterial blood clot formation, but using fibrinogen tests to detect this risk is limited. Currently, there are no specific treatments that directly lower fibrinogen levels, and no evidence shows that reducing fibrinogen decreases the likelihood of blood clots. Additionally, the different method used to measure fibrinogen levels need to be standardized. However, therapies like statins, quitting smoking, regular exercise can indirectly lower fibrinogen levels along with LDL cholesterol, and total cholesterol levels, the result of fibrinogen tests, tend to mirror those of other risk factors for cardiovascular disease. So next, this is the figure 39.9, coronary thrombosis risk prediction by fibrinogen and cholesterol concentration. Fibrinogen and total cholesterol synergistically predict coronary risk. Tertiles of fibrinogen concentrations are shown in relation to tertiles of total cholesterol concentration with the relative risk of coronary events indicated for each combination. So next is plasma homocysteine. Homocysteine is a naturally occurring sulfur-containing amino acid intermediate in the metabolism of dietary methionine. Fasting homocystinemia is an independent risk factor for arterial thrombosis, with relative risk ratios of 1.7 for coronary artery disease, 2.5 for cerebrovascular disease, and 6.8 for peripheral artery disease. Several theories link homocystinemia with coronary artery disease, most citing damage to the endothelial cell. The enzyme 5,10-methylene tetrahydrofolate reductase is required for the remethylation of homocysteine to methionine in the folic acid cycle, common functional polymorphism of the 5,10-methylene tetrahydrofolate reductase gene raise plasma homocysteine. Thus, some thrombosis risk testing profiles include molecular assays for MTHFR. Through MTHFR polymorphism have not been empirically linked directly to thrombosis. So, plasma homocysteine, hence homocysteine is a natural amino acid in our bodies made during the breakdown of proteins. Having a high level of homocysteine when fasting can raise the breakdown of proteins. Having high levels of homocysteine when fasting can raise the risk of artery blockage. This increases the chance of heart disease, stroke, and artery problems in the legs. Certain genes can affect homocysteine level, but it's not clear if they directly cause artery blockage. Homocysteine levels vary based on age and differ between men and women. They also influenced by the amount of folate, vitamin B6, and vitamin B12 in our diet. In some countries, grains are enriched with folate to prevent birth defects, which can help lower homocysteine levels overall. So, last one is the factor 8. Factor 8 assay are designed to detect factor 8 deficiency and may lack accuracy at levels greater than the upper limit of the reference interval, typically 150 U per dm. Like fibrinogen, coagulation factor 8 is an acute phase reactant. Consequently, an isolated case of elevated factor 8 may relate to acute inflammation and provide lethal thrombosis risk predictive value. However, chronically elevate factor 8 like chronic hyperfibrinogemia may predict both arterial and venous thrombosis. So factor 8 therefore are tests used to detect deficiencies in factor 8, a protein involved in blood clotting. However, these tests might not be accurate when levels are too high, typically above 150 U per dl. Similar to fibrinogen, factor 8 levels can rise during acute inflammation, which might not necessarily indicate a high risk of blood clotting. However, consistently high levels of factor 8 over time could indicate a higher risk of both arterial and venous blood clots. Symptoms of deep vein thrombosis include leg, leg pain, swelling, increases calf size, pitting edema, and visible superficial veins. A scoring system helps assess the likelihood of DVT, with higher scores indicating a higher probability. Other conditions like superficial thrombophlebitis, cellulitis, or venous insufficiency can mimic DVT symptoms. So that's all my report, and thank you everyone.